I often will use my audience analysis research to identify community partners. And I kind of figure out who are the people who are really excited and interested or into it, enthusiastic, and then invite those people to work with me. And so it's a kind of a, it's a chicken or egg issue. The thing that's critical is that I'm guided by culturally sensitive indigenous information from the communities that I want to work with, that I'm not, thinking ahead of time that I know what these people are all about and what they need. In fact, I think that's one of the really big problems in public health, is that there's kind of a, sense of I know better than you what your problem is. And there's kind of a paternalistic thing that, these poor people are so dumb, I can't believe they do this. They don't know that, they don't do this. And so we're going to fix them up, we're going to raise them up. And I think coming in with that attitude kind of sets everybody up for failure to start with, because people are not going to be eager to cooperate with you, to follow direction, to comply with recommendations if they feel they're being talked down to and they're not being respected. I think respect is probably one of the critical factors in social influence. And too often in health promotion, we kind of skip over the respect part. There's also the issue of coming up with interventions and strategies that make sense, that fit into that culture, that fit into that environment, that there are resources for, that can be built in easily. A lot of times we come up with strategies for intervention that really take dramatic changes that demand, totally re-engineering the whole social system. And, forget about it. That's not going to happen. It's just, there's this notion that the best interventions are ones that kind of supplement or refine or add or adjust, kind of change the course a little bit of what's going on already, kind of through a process of reinvention, as opposed to kind of revolution. And I think a lot of times the public health interventions are based on revolution. What we need to do is change everybody's diet, All right, from now on, you're not eating this. From now on, you're not doing that. From now on, and that just doesn't work. People are not going to do that. Even if they're forced to do it, they'll only do it when they're being forced. And so you got to make these changes gentle, and you got to make them appropriate. You've got to make them easy. Even better if you can get the changes to appear to be the ideas of the audience that you want to adopt the change. That's a wonderful thing, because then it's their idea, and they're wedded to it, and they feel a sense of responsibility. And it's not your dumb idea, this evil person out there making me do what I don't want to do. In fact, I think this is probably a good recommendation for administration and governance in general, is to kind of use kind of a bottom-up approach to change rather than a top-down approach, kind of a consensual model. And so a lot of times I use my audience analysis work to connect with people who are really enthusiastic about whatever it is I want to do. So let's see what I've got here in terms of my slides today. Yep, that's a work. Do we have to do something to make this work? Is there an on switch?
On the side, usually.
All right, you'll give it to me. I love technology, it doesn't love me. Hold it, yes sir. Well, then we just look at this slide. The entire.
Try it.
Try now. Hey, it works. Okay, there's no one right way to reach, influence diverse audiences. Sarah, you get to take this workshop for free because. Don't judge her for this. That there's everything needs to be adapted to the unique situation. I think that the more we understand about the context, the people, the history, the culture, the background, the better we are at designing interventions that are going to take hold. Unfortunately, there's a lot of a priori planning that goes into typical health promotion. A lot of times the planning is based primarily on the wisdom of the experts and what they think will work and what works for them. Problem is that the experts are often very, very different from the populations they want to reach, and ends up not working very well at all. So communication programs should be responsive to unique audience characteristics. A careful audience analysis should guide message design and channel selection. Designated audiences should be carefully segmented based on key shared cultural variables. And I really underline the carefully segmented part, because audience segmentation, I think, has probably been one of the best advances in health promotion in the last 100 years. There's this tendency by sponsors, usually government agencies, but also corporations, to want to get the greatest bang for the smallest buck. Let's do everybody. Let's do one set of messages and send them out to everybody. Let's use television, And then they come up with campaigns. I kind of remember the campaign, Just Say No. It was the Nancy Reagan campaign. It was supposed to work for everybody. And, and a lot of people end up thinking, I'm going to say no to the people who are saying just say no. It was too broad. It was too general. It didn't provide enough specifics. It didn't really fit the culture. And so what we need to do is identify who are the groups. So one of the issues with segmentation is figuring out what are the variables that you want to segment on. What are the critical factors? Is age? Is gender? Is geographic region? Is health behaviors? Is attitudes? Sexual orientation? What are the factors that are really critically important? And this needs some analysis, because you've got to figure out what are the characteristics that are leading to the kinds of health problems that you're addressing. And then what are the best ways of segmenting? You may have to segment into several different groups. Sponsors don't like that, because that means that you end up doing a variety of small, targeted interventions for different groups as opposed to one large one. It's more expensive. It takes more time. You've got to figure out, you've got to fiddle with a lot of groups, but it's generally much more effective. There may be some factors that cut across a number of groups and you can put them together. But typically it's kind of like the probability curve, that if you just do the general audience, you end up losing people on either end of the curve. And you end up picking up a very small segment of the population with your intervention. Close collaborations with audience members enhances communication effectiveness, and that's basically what I was talking about yesterday, is that it's through this collaboration and interaction with members of the audience that you identify who they are, what segmentation characteristics are, and what's going to work. Key questions to guide strategic health information dissemination effort. What do you want to accomplish? Now, this may seem very simple, but you'd be amazed. A lot of times I get called in as a consultant, as an evaluator, to evaluate why health promotion campaigns are not achieving your goals. And you have no idea how many times I've done this thing. It's basically kind of a mopping up role. I come in, they spent $1 million, they haven't gotten the effects they want to know why it didn't work. So I come in and I start interviewing the people who are in charge of the plan. I say, well, what do you want to accomplish? And there's 5 different people, there are 5 different things. I said, well, what are the critical issues? And they have a hard time figuring it out. A lot of times they, instead of really identifying what the real major issue is, they're focusing on symptoms. They're trying to identify, what the outcome is rather than what the cause is. And unless you really have a good idea about what it is you want to accomplish, you're not going to be very effective. This is basically persuasion 101. If you don't know what it is that you're trying to persuade people to do, how are you going to provide them with good evidence and motivation to do it? So I think you need to kind of do a really careful needs analysis of what is the problem, what is the underlying problem, what are the issues, who do you want to reach? And more often than not, I hear people say everyone. Well, that's impossible. You're not going to do that. Consumers, all consumers. Are you going to use the same strategy? And so this is where the segmentation thinking comes in. Who are the people who are really most impacted by the issues that you want to address? So you've identified what the problem is. Now you say, who are the people who are really being hurt by these problems and people who need help? And then you might start thinking about it in terms of which are the groups that are most ready to adopt changes. I love these stages of change model that Prochaska came up with. It's a really nice one that looks at readiness for change. And it reminds me of the old research, communication research on ego involvement theory. I don't know if you remember this. Is Bandura and all these people who were doing research on attitude change. And they found out the people who were most ego involved were the most difficult to change, because even when you gave them good information, it just made them more, reinforced in their position. They wouldn't accept it because they were least ready to change. So I think that, if you can find people who are wanting to change, who want to do something, but just don't know how, then you've got a real advantage. And then if you have groups that are really hurting, who are not in that camp, how do you move them towards a greater readiness, greater receptivity to hearing your message? When people are polarized against your position, I don't want to hear this stinking message, tell me about it, I like smoking, smoking is good for me, get away from me. Telling them to quit smoking is not going to help very much. So maybe you want to move them a little bit gently with your campaign towards, well, maybe smoking is not such a great thing. Maybe there is an opportunity to change, maybe this is good for me. And then as you move them over, then you can give them a stronger message. What do you want audience members to do? And then the unspoken part of that question is, can they do it? What do you want them to do? Do they have the resources to do that? Do they have the knowledge? Do they have the capability? Do they have the inclination? Do they have support? Do they have reinforcement? Do they have funds? Can they afford to do what you want them to do? Are there resources in the environment? And a lot of times I find that the campaigns don't work is because they're tremendously unrealistic. They want people to do things that they don't have the ability to do. They don't have the resources. The environment won't support it. May not even be allowed, maybe against the norms of their culture. So we need to think through, if you want to be effective at instituting change, you've got to identify things that are doable, that are the low-hanging fruit, the things that, people can get done. If you go against, something that's not likely to happen, that's why the abstinence programs don't work, People have raging hormones, you say, no, don't just, They found out that the people, the young people who signed abstinence contracts were much more likely to engage in unprotected sex than the people who hadn't signed it. Because it was just so difficult for them to change. It was just unrealistic to come up with that kind of a message. What are the best ways to reach them? This is a communication channel issue. It's also a communication source issue. It's also a message design issue. How do you reach people about these issues? Or what are the channels that they're willing to pay attention to? One of the biggest problems I find in health promotion campaigns that don't work is exposure. That there's limited exposure to messages. That you put out messages and nobody pays attention to them. Sometimes it's limited exposure because the messages are being aired at 3 o'clock in the morning on a publicly sponsored public service announcement that nobody's paying attention to, and if they're awake at that point, they're kind of zoned out. Sometimes they're not paying attention because it's not a very attractive message. People don't want to hear it. Sometimes it's not on the right channel. And so you got to figure out how do you reach people. So you've got to figure out what are the communication channels that people are using, and which are the ones that they trust, and who are the sources that they want to hear from. And there are different sources that work for different issues. What messages will be most compelling and influential for key audiences? And I think this is a message testing issue. You can do some, assumptions, you can think about it, but the truth of the matter is that if you're not part of this community, it's very difficult for you to understand what works and what won't work. So you really need to do is to test different messages with, samples, representative samples of your community. Hello. Key information to gather about marginalized audiences. I typically work with marginalized audiences because they're the ones that often have the worst health outcomes. By marginalized audiences, I mean primarily poor people who don't have tremendous resources, but also it could be people who are stigmatized because of race, because of gender, because of occupation, because of disease, because of mental illness. There's amazing how many marginalized populations there are, and those marginalized populations often don't have access to the resources and the information and the support they need for good health. Oftentimes the healthcare system are not receptive to them. Recently, I just agreed to work with a new project, I think I mentioned yesterday, with issues that gay and lesbian people face with the healthcare system. I'm starting to look into it and recognize how tremendously marginalized these populations are, particularly the lesbian women have tremendously bad health outcomes, feel really ostracized by the healthcare system, feel that the healthcare workers don't treat them well, don't want to go to the doctor, often will suffer in silence, and because of that, the outcomes are very poor. And so you got to figure out, if this is the audience that you want to reach, what are the kinds of issues that they face, and what are the kinds of concerns that they have, and how do you reach these audiences? So relevant beliefs, values, norms, and expectations are some of the critical data points that I try and gather. It's basically psychological set. Psychological set and cultural orientation, I think, are some of the critical factors that motivate health behavior. It's basically the health belief model. Health beliefs are very powerful, but you need to figure out where people are getting these beliefs from and how strongly they feel them. And then how what you want to do connects with these beliefs, values, norms, and expectations. Language skills and orientation. And this is an interesting one because often we think that if people speak the same language, let's say English, or whatever language it is, that they utilize the same terminology, but they don't. The different groups use the same language in very different ways. And if you speak to people in the language that they're comfortable with, it's very difficult to connect with them on a very personal level. People are very sensitive to the incorrect use of language for their group. And you've got to frame whatever messages you're using in ways that are appropriate. And even if the words are appropriate, if it's the wrong source saying the right message, it will not be accepted because they think that you're posing or trying to manipulate them. So it's a really complicated set of issues. Sometimes I'm amazed that a lot of health promotion campaigns use languages that are not the primary language that people use, and they think it's going to be effective. Now, that's really pretty dumb. And then the orientations to language, I think, is a critical part of that as well. Health literacy levels, and literacy for me means both language and numbers, numeracy. And there are really big problems with many populations. Literacy is a really interesting issue. I think that research estimates of literacy basically say about half. This is the US-based studies. Half of Americans have problems with health literacy. And I think that's really an underestimation because it's basically they're trying to evaluate literacy from a trait perspective. Like intelligence, education, income, that your literacy level is a trait. And mostly they're looking at reading ability. Most of the tests of literacy are looking at reading. But I think that literacy is as much or more a state as it is a trait. And I think the fact of being sick, of feeling bad, of having fever, of being anxious, reduces your literacy level, particularly your health literacy level. And that's why people who are very well educated, even people who are physicians who encounter health problems, don't understand very well, get confused, get frustrated, because they're encountering those issues that make them, anxious, make them worried. Often when you're sick, you're taking medications to relieve pain. The medications dull your senses. Sometimes you have nausea. You're not at your best when you think you're going to upchuck at any moment. Sometimes you're terribly tired and fatigued, and think about the times when you are at your worst in terms of being aware and conscious and involved and on top of things, and almost all the factors that lead to illness are factors that reduce awareness and acuity and involvement.
I'm sorry, Gary. So the numbers here you refer to the percentage
of people who understand the messages?
No, it means that messages that we present that are numerical messages, like statistics.
Okay.
Like if we say 1 in 8 people are likely to get breast cancer, people, understand that in very different ways. In fact, there's a really interesting study that shows that there's the same percentage of risk, pretty much, between breast cancer and prostate cancer. And women who get, I think it's 1 in 6 is the message. And women who hear the message 1 in 6 basically perceive that as that it's a 50-50 chance. And men who hear that same message about prostate cancer think it's like 1 in 1,000. It's a very bizarre situation. And it has a lot to do with sensitivity to health issues, personal concern, and also the media environment. There's a hell of a lot more media messages about breast cancer. And the breast is a much more sympathetic organ than the prostate. People don't even know what the hell a prostate is. If I ask you to draw a picture of a prostate, what the hell would you do, But if you ask people to draw a picture of a breast, they would know right away. And there's also, all the issues of maternal and, child rearing and nurturing, and also the sexuality of breast that makes it a much more appealing and important audience topic, and people are checking that out. That's it's one of the things that men and women look at breasts, but they don't think about prostate, and then all the publicity, all the the pink ribbon stuff, and the races for the cure, and by doing that, it's raised awareness at such a rate that people overestimate the impact. They don't realize that there are far fewer women that die from breast cancer that die from colorectal cancer or lung cancer or heart attacks because it's been hyped up so much. And so it's that numerical issue. And most people are not really good with numbers, but a lot of health messages use numbers and statistics a lot. And so there have been a lot of strategies of ways to try to change that. Use pictures, use examples, embed the statistics within a narrative that people can understand. But it's one of the factors that makes health messages so difficult to understand. I was working on a project a couple of years ago where I was trying to improve the understandability of federal health websites, basically NIH, CDC websites for the public. There's a law that says that the website should be at no more than the 5th grade reading level. But when we analyzed them, they were about the 11th grade reading level. And a lot of the complexity was because of all the numbers that were in there, and people just did not understand. So I think when you think about literacy, you need to figure out how much do people understand, and what are the situations that they're facing that lead to misunderstanding. I think that misinformation, misunderstanding, and uncertainty are the primary factors that lead to breakdowns in health communication. And in fact, I would say that 90% or more of the work that I do, just use a statistic there, but this is probably a high numeracy group. I think that most of the work that I do is focused on reducing uncertainty and increasing access and understanding and usability of relevant health information. So I think that if you can think about what the literacy levels are, it helps you come up with strategies that are likely to be understandable. This morning I was emailing with a former NCI colleague about some research I'd been doing on medication adherence. I'd done some research where we identified a set of motivational messages, message library, that could be used to help people analyze areas of uncertainty they had about medications they were prescribed. We're talking about why that was so important. And the assumption is that I have is that a lot of reasons why people don't take their medication is they're not very confident that it's the right thing for them to do. They don't know what the implications are. They don't know how it'll fit into their lives. They have a lot of unanswered questions. So my strategy has been to help promote better adherence, actually better prescription drug decision making, is to provide people with relevant information targeted to the areas of uncertainty. And the testing of this intervention has actually worked quite well because it helps people understand more. And instead of just opting out because they don't know what's going on, they make good decisions. Unfortunately, my funders for this, the pharmaceutical industry, are not really interested that much in good prescription drug decision making. They're much more, interested in adherence. Because sometimes the best decision that a person makes is that they really don't need that drug. Oh, they shouldn't take it, and that's not the decision that they want them to make. They want them to make the decision that, yes, I'm taking the drug you prescribed it for me. I'm going to take it reliably. I'm going to pay for it all the time. It turns out that the pharmaceutical industry is losing billions of dollars every year because about half or more of all the people who are prescribed medicines don't take them, don't buy them, and that's a real big issue for them. It's more of an issue to me that these people are not being helped by the therapeutic regimen that they're being prescribed. And most of the time, I would say the majority, most of the time people are prescribed medication because they need it. And it's to help them, and if they don't take it, it's probably exacerbating whatever problem they have. What are the levels of motivation to seek health information? And this goes back to that ego involvement and the readiness to change issue that we talked about a little bit earlier. When I'm seeking information from people, in many ways, this is kind of a backdrop, kind of like the between the lines issues that motivate the kinds of questions I use in surveys and interviews. Mostly I do interviews. I like doing audience analysis with open-ended personal interviews where I have kind of a set of general questions, but then I can probe for more information. And these are the issues that I ask when I want to find out what do they believe, what do they value, what are the norms, what are the expectations. I listen to how they're communicating. I want to find out what the words are. I want to assess their literacy level. I want to figure out what their levels of motivation is to seek health information. I want to find out what their media use patterns are. What are the channels they're likely to use? Which are the media that they trust the most? Are they interactive media? Are they new media? Are they watching television? Are they getting information from newspapers? Are they talking to friends and colleagues? Social network memberships I find is critically important. And more in the last 5 years I've been developing interventions that tap into social networks. The really nice thing about social networks is that they're relatively inexpensive to motivate because you don't have to pay for them. You just have to tap into them and get people who are parts of those networks to participate. They're enduring over time. They're very interactive. And they're very influential. The bad part about social networks is they're very hard to control. And then people may be saying things and doing things that you don't want them to say and do that may not be part of your message. It's not like you take an ad and you know that the ad's going to say what you want it to say. So you've got to really stay close to the people in the social networks and train them and support them, provide them with materials and evaluate what they're saying. Because once the message starts going the wrong way, it can really sour your intervention and make things work in ways that you didn't expect them to work, often in very negative ways.
When you say social network membership, are you talking about social media? Or are you
No, I'm talking about friends
and peers?
Family, colleagues, people you interact with, close ties. Who are the people in your personal network that you interact with? Sometimes it's social organizations. It's different for different people. Sometimes it's religious organizations. Often, family members are really critical ones, except for with the young children, adolescents. They don't want to hear from their family members about these things. They really, in fact, we found that getting parents to tell adolescents what to do has a big boomerang effect, because they don't want to accept that. Peers work really well. So you've got to figure out what are the social networks and how influential they are. Priorities for designing effective messages. And so these are the things I'm trying to achieve. Make messages interesting. Now this may sound really, really simple. But take a look around at some of the health promotion messages. Next time you're in a clinic, look at some of the pamphlets. They're boring. They're boring. They're not interesting, and sometimes they are irritating. And they're insulting, and sometimes they're disgusting. And so you've got to figure out what do people want to hear about. I mean, the people who do marketing and advertising for products and services are masters at this. These are the people who convinced people that toothpaste was sexy. You know, there's nothing sexy about toothpaste, but there's the multi-million-dollar campaigns out there that says that if you use this toothpaste, you'll have sex appeal and you'll sparkle and you'll be so attractive and people will love you. And amazingly, people believe that. We've got to become as clever as those folks in terms of designing health messages that are exciting and attractive. I did a study a couple of years ago for the CDC Foundation about encouraging women of childbearing age to use multivitamins. It was an issue about iron and there's a I think is it called folic acid?
Folic acid.
Folic acid, right. If you don't have enough folic acid, women of childbearing age are likely to have or could have different types of abnormalities in children that are very dangerous. The CDC had been trying for years to get women to increase their folic acid. If you do it naturally, you have to eat like a ton of spinach every day. It's not going to happen that way. But if you take a multivitamin, you can get all you need and more very easily. But they had tremendous resistance, and they were showing messages about negative birth effects, and they were scary, but they still weren't working. So a research group and I ended up doing focus groups with women around the U.S. in different sections of the country to find out what it would take to motivate them to take multivitamins. And it turned out that the fear of birth defects was not on their agenda. Many of them were saying, I don't plan on getting pregnant, it's not my issue. The thing that was really going to motivate them is that if we could convince them that taking multivitamins would make them more attractive. Primarily if we could convince them that taking multivitamins would help women lose weight.
How do you get the answer?
How do you know? No, I'm very curious because
Yes.
when you have the focus group, right? Do you really ask them, okay, what should we do to motivate you? How do you get that answer?
Well, we asked them, why would you take multivitamins? What things about multivitamins would be really interesting to you that would motivate you to take them? And we had women talk about that. And invariably across all segments of the country, if the multivitamins would make them more attractive to potential mates, that was going to do it. And if it made them lose weight, they would do it.
Well, that's even better, yeah.
Unfortunately, there was really no evidence. I basically told the CDC, do it anyhow. I don't care if there's no evidence. There's no evidence that there's sex appeal in toothpaste. Just tell women that taking multivitamins is going to make you sexy, but they wouldn't do it. But the best we could come up with, we did find evidence that taking multivitamins would give you thick hair.
Makes your nails grow faster.
Right, and strong nails. Thick hair and strong nails, and so that's what they did, and it worked pretty well. It would have worked better if they could have said it would make you lose weight, but they didn't do that. But I think understanding those issues are really critical, understanding what are those motivating factors, and making sure that the messages are interesting. Obviously the message that, birth defects, if you don't take multivitamins, your children can have birth defects, was not an interesting message. People did not want to hear that. They didn't want to think about that. It was just, the more they told, the less they were interested, and the less exposure they got to that message.
It must have worked a little bit because a lot of my friends in college took prenatal vitamins because they said it would make their hair the same,
Right.
hair and nails.
They did, and so that's what the CDC, and they
Yeah.
loved that because it actually did work.
Uh-huh.
I think it would work better if they said they would lose weight.
Well,
That's the difference between social scientists and those people doing marketing.
Yeah, exactly.
Yeah, you cannot lie.
You can say you could lose weight. Close enough.
Individual results.
9 out of 10. Doctors say. I was going to do those commercials. I wonder if 9 out of 10, all 10 of them work for the company. Make messages engaging. And by engaging, I mean that encourage people to talk about them, to think about them, there's this a really interesting model about how engaged you are in an issue, the level of thought that you have, high involvement. They find out when you're engaged more and you think about things, you're more likely to be influenced. And so you want to engage people actively. Make messages relevant to people's unique situation and condition, which means you've got to figure out what is their unique situation and condition. Make messages easily accessible to improve exposure, which also means that you provide them through a variety of different channels. I would never put all of my health promotion, intervention, efforts into one basket. I wouldn't say, a lot of people say, let's just use TV or let's just use posters. Posters are really big in public health. They love posters. And I'm not really convinced that posters work very well, other than maybe to increase a little bit of awareness. They certainly are not going to change behavior. I don't know anybody who saw a poster and said, well, I'm going to change my behavior. I'm going to live my life differently because of this poster. I think we need to have more involving, interactive channels. And so I often will try to mix both interpersonal and mediated communication. My experience has been, and the evidence suggests, that mass-mediated messages are much better at agenda raising, raising the agenda and saying this is an important issue, but not very effective at changing behavior. And interpersonal channels, especially from close personal ties, where there's a lot of social modeling. This is based on Bandura's social learning theory, is that people will change behavior by modeling over time. So I think you've got to connect and get people involved personally. Whoops. Make messages persuasive. And it's kind of a funny thing, because when I say this to public health people, they have a negative reaction, like I'm saying we can kind of manipulate people. For some reason, persuasion has gotten a bad name outside of the communication and psychology disciplines. We think persuasion is a good thing, but people think persuasion is bad. That if you're persuading people, you're pushing them around, you're manipulating them, you're taking advantage of them. But the whole issue of social influence, I think, is critical to health promotion. And so you've got to think about what are the factors that are going to be persuasive for an individual. What are the factors that are going to move them? What are the things that they're going to, really personally involving? And then design multiple reinforcing messages that can be delivered over time. I think this probably is the factor that's the biggest problem with most campaigns, is that they're one shot, one trick, this is it, you see it or lose it, and you don't keep on it over time. I think it's a lack of recognition to the complexity of behavior change, that we're not really thinking carefully about what it is that will really move people and reinforce them and keep them changing over time. One of the big problems I've noticed, and it's been documented in the literature with campaigns, is they have very short-lived effects. And so that, you may get a change and then people revert back very quickly. It was one of the problems I had with the HIV safe sex messages that were so effective in the 70s and 80s with the gay population, is that once they stopped, really pushing it, people reverted back to old ways of doing things. And so the AIDS infection rate went back up. So you've got to find different ways of reinforcing over time. It also means that you've got to change the messages, because the people kind of get inoculated to the same message over time. And you've got to design the messages so that they are reinforcing and they are encouraging and they're moving forward. So it means that you've got to continually monitor what's happening and what the responses are to the message. So when I talk about message testing, I don't only use it in a, in message planning and design, but I also do use it as a form of formative evaluation, that throughout the, the term of a campaign, I'm constantly collecting data to find out what's going on. You don't necessarily have to do that with huge populations, but I think if you continually kind of monitor how people are responding and reacting, you get some good strategies about changing messages over time. Avoid messages that are And this is like a list of, these are the campaigns that we see out there now. Avoid messages that are difficult for key audiences to understand. Duh. I mean, but if you look at the information, health information, look at pamphlets, look at websites, it's not easy to understand. It's not easy for me to understand. I've worked with the pharmaceutical industry for about a decade now, and they continually tell me that patient package inserts are good forms of health communication for educating patients about the risks and benefits of medication. How often do you read the package inserts? And if you do read them, how much of it do you understand? Now, can you read it because the text is so small, and the words are so big? And if you do read it carefully, it's very scary because they list all the possible things that can happen to you. So it's not a very good way of communicating. You've got to come up with better strategies. The problem is with the pharmaceutical industry, although they will not admit this, is that I think that they really don't care whether patients understand. They care that they're meeting legal requirements, and they're not going to be sued and not going to be prohibited from selling the drug. And I think the proof of that is if you look at, I don't think they do this in Singapore, but in the US they have a huge industry of direct-to-consumer television advertising of prescribed medications. In fact, I think about a third of all of the television advertisements in the US, maybe even more, are now medications. In fact, the TV industry thrives on this. I have friends who are middle-aged or older actors who are living because they're employed to portray, people who are getting benefits from Viagra or whatever it is, Motrin, it's a huge industry. And if you look at those advertisements, they're supposed to be giving equal, risk and benefit communication information, but they put almost all of their messages into benefit communication and very little in risk. All of the images are benefit images, all of the music, all the faces, all the words, and then at the very end they say, however, and if you listen to some of those things, my God, it's scary, but nobody hears that. Because the negative things are often a lot worse than whatever it is. The medication is to remove blemishes, but the risk is that you could become paralyzed and die. Avoid messages that are boring or unimaginative. Avoid messages that are intimidating or too frightening. I think we overuse the fear appeal in health promotion. Now, I'm not saying that fear appeal is bad. I think it's actually quite good when awareness is low. I think there's probably nothing better than a good fear appeal to raise awareness.
We should show you some of the messages in Singapore. They live and die by fear appeal.
Oh, really good. Well, that's the way it is in most. That's
nothing else.
the problem is that once people are aware of the problem, the fear appeal has a boomerang effect, and that people start blocking it out. And if there's not a good way, this is basically Kim Whitty's research, is that if there's not a good way for you to act upon the fear, then you supplement it. So you need to not only provide fear to raise awareness, but then you need to build on it. This is what you can do. This is where you can reduce that problem. But we're much better at scaring people than we are at helping them, which is a shame, because isn't health promotion supposed to help people? Not supposed to scare them? So I think that's a big issue. A lot of times the messages are quite insulting, because they're basically saying you are a bad person. You don't behave the way we expect you to behave. We don't like you very much, and you're not valuable, which is exactly the opposite message we want to do, because we want to build self-efficacy. We want people to say, I can do this. I can lose weight. I can, stop smoking. I can eat healthy. I can exercise. But the messages are basically saying you are bad. You are worthless. You are, the scourge of the earth. And now we want you to do these things. To me, they say, get away from me. I don't want to hear this, I don't like this, I don't like you, I don't like your product. It's just the opposite effect. So I'm really into positive communication for health promotion. I think we use too much negative communication.
So there's a ad I use in my class. It was running recently in Singapore, and it's about binge drinking of college students. But the image and the message is of either young men or women who are tattooed and pierced from head to toe. First of all, when you see the image, you go, huh? What does that have to do with binge drinking? Right? And then second of all, the message really says, you know,
Not me.
no, like, you know, you're going to be bad as that, right? If you binge drink. And it's just sort of like, okay, you know, who came up with this, you know, idea? I mean, and you show it to our students and they laugh because, I mean, you know, any normal a person would first of all say, okay, first of all, what is the connection? And then second of all, it really is about creating a stereotype of a different, you know, people who are tattooed or who have piercing, and then, you know, it's, rather than saying I won't binge drink, you might then hold a stereotype towards, and you walk down the street and you go, oh yeah, that person is bad. But that's a binge drinker, right? But that's not me because I don't have any of those things.
And double
Yeah.
negative
Yeah,
effects.
double
And
negative.
binge drinkers
absolutely.
are not tattooed. They look exactly like me and probably Sarah.
Yeah.
Yes, because they are your normal students
Yeah.
that would binge drink.
Who is the target audience?
Yeah.
By the way.
And who are the people who have been drinking? Are they the tattooed, heavily pierced
No,
people?
no.
You know, the people who are
College
drinking are
students.
probably, you know, the people who are, you know, wanting to make friends and have fun and, you know.
Vegetarian. Vegetation would apply.
Yeah, those vegetarians.
Vegetation or meditation?
Meditation
Oh.
and being vegetarian.
The vegetarians are a very dangerous group.
Very highly dangerous group, yeah.
Can you see the advertisement on YouTube?
Yes, you can.
I think it's because they
So
haven't
they
had a
have
lot of
the
meat, they
print
feel violent.
version as well as you know, on YouTube it's the ads that were running on TV, I think, and then there's print versions too.
So I think what you want to do is you want to have messages that people can identify with. And you don't want to polarize them. On the other hand, if that was the group you wanted to reach, maybe that was the right, but I don't think that is.
No, it's not. No. It's college students.
Overly directive and prescriptive doesn't work very well. Telling people what you want them to do, when you want to do it, how you want to do it. I think you've got to give people some room to make this work within their own lives and give them alternatives. So a lot of times when I do health promotion, I say, you know, here are different things that you can do that might work. Here are sources of information for you so you can make your own choices. There's a form of a reflective interviewing called motivational interviewing that I really like as a behavior change strategy. They use it a lot for substance abuse and also mental health issues, where they don't really tell you what to do, but they give you a lot of choices and they let you ruminate and think about what will work best for you. And then you own the intervention, you own the change. I think being overly prescriptive reduces self-efficacy. So anything that reduces your ability to feel in control, powerful, effective, able to achieve your goals is negative to the goals of health promotion. Best health messages and media channels should be selected to channels that are, you know, dramatic and vivid. I think are the very best ones. So what are the most vivid and dramatic channels of communication that you could use? Let's say for you, because you're an audience you understand very well. So what would be dramatic and vivid channels for you?
Can I provide a negative example? I once took a bus, and then the whole bus was read by black and white visuals. It's the Health Promotion Board's dengue fever campaign. So it is really about, okay, if you got dengue, then you feel very painful, and then dengue would be pretty fatal. But then the whole bus was wrapped by that black and white color, and then
mosquito on top, no?
yeah, and then mosquitoes. The whole color theme was black and white. And then you enter into the bus. Usually in Singapore, inside the bus, they shouldn't have any advertisements. But then for that, because that's probably government-sponsored campaign, so inside the bus, the double-deck bus, all the back of the seats, they have that black and white, posters and the visuals there, and just like people lying on the hospital bed, it look very painful. And then I feel like, okay, am I looking into a tomb or something like that? And am I sitting next to corpse? It's very, it's very uncomfortable feeling, but
it's dramatically vivid. So.
but that also links back to the earlier discussion, right? So I think that's a clever idea that you use this kind of channels because it's really linked with person's everyday life, but sometimes the message design is just like, okay.
Sometimes it's overkill.
Right.
Sound like it was overdone.
Right. You have that strong feel arousing messages, but actually it doesn't really help the audiences to enhance their empathy
And do they give you recommendations for what you could do to reduce your
No, they
change?
just tell you how terrible that you would be if you got that key. Yeah, so it was okay.
And so what are the recommendations for reducing the incidence? Is that to avoid contact with mosquitoes, to put repellent?
Yeah, I think now they improved the campaign because firstly, I think they pay more attention to who the target audiences would be. In the past, it would just be everyone, and then have this giant mosquito, model put on the billboard, next to the bus stop. But students just feel that's funny. But nowadays, they improve. They target at parents. They tell the parents that, okay, if you don't pay attention to clean your house and then clean those water, then your children will suffer. That worked. And then they also specific one. And then they also provide some really techniques that you can practice so that you can prevent mosquitoes to brood in your place. So that works better than the previous campaign that focused mainly on how scary this disease.
And I guess what's unique about Singapore also is that if you have a sighting right of a dengue mosquito, or if you have a suspicion, if you call NEA, they will randomly show up or check and make sure that the pots are not stagnant. So they have that part also to implement it. But I guess it's only true of dengue. It's not like for every health message is there that they're doing that. But yeah.
It seems that this health problem is one that government intervention is really the primary factor for reduction of threat. Is that they can spray and get rid of mosquitoes in the environment. It's the most effective way of reducing rather than the individual. It's one of those interventions that has to be structural and is on a larger level. So maybe the encouraging of the reporting so that the government can do their work. But scaring people about the disease is not going to reduce the threat.
The message tagline is, it's your responsibility. The message tagline, they have all of these images and all of this, but the bottom line is, it says it's your responsibility, it's as, individual behavioral change.
Yeah, I don't think that is. I think it's more of a societal responsibility, or at least a government responsibility, public health responsibility. And I think you got to figure out which of the things are individual choices. It's not an individual choice whether you encounter a mosquito or not. This is not like it's not like a willpower issue or thinking through your menu for the day. It's one of these things that what are the risks in the environment. And so if there's an environmental constraint that they can reduce through policy, through programs, through activities, I think that's got to be the focus. Now if they can get consumers to help promote that by identifying when and where to use those programs and policies, then that would be a much smarter campaign. Then that goes back to the earlier issue about what are you trying to achieve? What do you want people to do? So that seemed like probably a fairly expensive, intensive intervention that is not really helping to get people to do things they needed to do to reduce that threat.
And especially in Singapore, most of the campaigns actually are run by the government agencies. For example, like the Health Promotion Board and the National Environmental Agency. And then we talked with people at the Health Promotion Board before, and then this is run so many campaigns, like 60 something per year. So that's pretty heavy.
And the one that is fair.
Yeah.
And so is there much work going on between collaboration between scholars and the Health Promotion Board? Because that would be a wonderful thing to do. I wonder if there'd be a way of, I suspect, and I find that a lot of the government agencies that do health promotion are dying for help. They would love to get some guidance. They'd love to have somebody help provide them with audience analysis data and strategic message design, informative research.
I guess
They
for
work with us.
informally, right? But I think because they do have a lot of money, so they probably tend to, get consulting, or they have a lot of in-house people who do that. Not to say that they're all trained in public health and health communication, but they certainly have the money to be.
It sounds like it would be a good idea to maybe make some contacts with people in the positions of authority in the health promotion world and let them know that you have that kind of expertise and you're willing to help them, and maybe can include it as part of some activities you're doing. Maybe you would be able to have a contract with them or a grant.
Yeah, we were just talking about that. We deeply regret that we didn't inform, the health promotion board people to come to the workshop.
I was just thinking.
Yeah,
Well, maybe-
I feel
This
very
one,
bad.
right?
So maybe we should put you in contact with some of them, and then if you have time, maybe they
Particularly
should
this
invite
one.
you to the health promotion board to talk about.
Because this is exactly the kind of work that I'm doing right now with the CDC in the US, is that we're training the people who do the health promotion campaigns for the nation, for the CDC, how to do message evaluations and campaign design and message testing.
Every slide was like, no,
Exactly.
you should read it.
Yes,
Right.
yes.
Right.
Adapt messages to key audience preferences so that there's not the same message. Good luck with your plan.
Right.
Design multiple complementary messages. Illustrate concepts both visually and narratively. Provide encouragement and empowerment, which is, obviously what they're not doing with the mosquito thing. Provide specific achievable action steps so that people can actually do what you want them to do. And then enable review wherever needed. One of the big problems I find with health promotion is that the messages are very fleeting. They go by quickly. And even if they're interesting, they don't really take root. And if you don't provide opportunities for people to hear those messages again and review them and get more information. For example, one of the things I've been trying to do with online health information systems is give people opportunity to click to get more information. So if there's an issue that they find interesting, those topics are highlighted and they can click on that and takes them to a page with more information, references, other things. Sometimes it'll say, for more information, click here. And you can, it seems that, a lot of the commercial websites are much better at doing that than the health promotion. I mean, the Amazon.coms, even the Facebook, people have things that you can kind of click on to get more information. But a lot of the health promotion are very static. It's just that one thing. You can't really push for more. And then I think there's the issue about whether you want to make it user-generated searching, or you want to try to push the information to people, send it to them on a regular basis, like through tweets or through messages or texts or emails, as ways of reinforcing information. Be adaptable over time. Recognizing that health promotion campaigns are kind of short-lived in their effectiveness because things are changing. The nature of the problem is changing, nature of awareness of the problem is changing, societal constraints are changing. As we learn more, we need to adapt the message. So it's kind of like a relationship you're building with the consumers that you're working with. You can't just say the same thing over time. Maybe saying hi, how are you, is good, the beginning. But if you just keep saying hi, how are you, hi, how are you, hi, how are you, it gets really old. That's where do we go from here? What's the next step? And so I think we need to make the campaigns more relationally sensitive and adaptive over time. Select communication channels that are close, familiar, and easily accessible. Easy for key audiences to use. And this becomes a problem, especially when we're talking about new technology. It depends on the audience, whether they can use the information, whether they have access to the information, whether they have broadband connection, whether they have the kinds of software or hardware that's necessary, or they have the inclination to use those tools. There's been a really big push to use social media for health promotion campaigns. And I think there's got to be some really careful thought about who's using those social media. And the social media patterns are changing quite rapidly. The Facebook audience is becoming much older. A lot of young people don't want to be on it anymore because their parents and the grandparents are monitoring what they're doing. It's kind of a weird situation. And so you've got to figure out what are the media that are effective, and then how can you get them to illustrate. One of the things that has become really attractive is the use of video, like the iTunes kind of video channel, YouTube, right? YouTube channel is become if you can get a viral video going about a health promotion issue. The thing is that a lot of the viral videos are not very health oriented. They're more like people doing bad things, or getting hurt. Those are it's kind of like my favorite videos are nasty things. You need to figure a way of kind of getting people's attention. And also, there's not a lot of depth to them. You got to, make sure that you connect the video up with some activity. I was recently contacted by the Department of Transportation in the U.S. who wanted me to help them develop some viral videos that would get young people to not text and drive at the same time. And their idea was that if we could show some videos of people really getting hurt through texting and driving, that it would help. And I think that would be a good way of raising awareness, but it doesn't really move it far enough. It's become a really big problem in the U.S. I don't know if it's here too. I've noticed some drivers texting and driving at the same time. But the tendency for serious traffic accidents when people are using different smartphone media is really a big problem. Dramatic and memorable messages and channels, reviewable over time, interactive I think is really a critical factor. And there's not a lot of interactive health promotion. I think that you've got to build in different ways for people to communicate with each other and seek feedback. Reinforcing over time, entertaining, best information sources. Who are the people that you want giving your message? And think about some of the health promotion messages that are being presented. Are there doctors? Are there officials? Are there celebrities? Who are the most credible sources on different topics for different audiences? And this is part of an audience analysis question. You've got to find that out. You don't know who are the most credible audience sources of information for you. Who would you believe? Would it be a peer? Would it be an official? Would it be a celebrity? Celebrities have a lot of cachet. Jenny McCarthy has had a bigger influence on people getting immunization for children than any other source. That's one of the biggest problems, is that the Surgeon General does not have the cachet that Jenny McCarthy has. I recently saw a post that she admitted that her child actually does not have autism, has some other problem. Whoops, never mind. And all these years she's been saying that it was caused by immunization, by vaccination. Our familiar sources are the ones that are most compelling. And I find that a lot of times, instead of having people who are distant experts, if you could have people you know who can give you personal testimony about what's happened to them and what they've done. And that's why I think a lot of times online support groups, discussion groups can be very powerful for influencing others. Sometimes I think the fact that people are like you and have similar situations and similar experiences makes a lot more sense than somebody who's very distant, who you don't identify with very much. Our expert source is influential. And I think you've got to think about, when do you want an expert source? When would you want an expert source? I think maybe the more complex the message is, the more research-based the message is, the more it is that you're trying to help people understand then the expert source is best. But I don't think the expert sources are very good for getting you to adopt behavior because you don't identify with them. So the use of sources depends a lot on what your specific goals are and what the kinds of messages that you're providing are. How effective is peer communication? When do you want to use peer communication? When is it not very effective? When you have a very complicated scientific message, I don't think peer communication is the way to go, unless your peer is a scientist. So figuring out when that works and when it doesn't. What other sources will work? And a lot of times we don't know what sources will work until we find out from people who they're influenced by. So I like to do kind of a social network analysis, where I'll try to ask people who they communicate with, what do they communicate about, what influence that has, and try and do kind of a sociometric analysis of what those connections are. And then you can identify the kinds of individuals who are the gatekeepers or who are the influencers, who are the people who can really get them to move. Formative and summative evaluation strategies need to be used to guide program design. And so formative research, you probably know, is the research you use to develop and refine. And summative research is what you do to try to figure out what's happened, what worked and why it worked, and how effective it was. A lot of times formative and summative research work together because the formative research provides some of the baseline data for identifying major changes over time. So I believe strongly that all health promotion has to be based on a research platform. It's probably my own background, but I really think that you need to have good evidence to guide what it is you're doing, and then you need to utilize it throughout the entire process. Not only for determining what you're going to do, but also for demonstrating to your host, to your funders, that what you're doing is appropriate, is effective, and it deserves their investment, not only now, but in the future. It also is a great way for you to demonstrate that you made a difference if you want to publish your work. So a lot of times the formative and summative evaluation work that I'm using to design, implement, and evaluate my campaign are also the same data that I'm reporting in publications, because you want to demonstrate that you made a difference. So the same kind of rigor that you would use in any research endeavor, I think has to be put into the development and design of evaluation programs for health promotion campaigns. And that's not always the case. In many situations, there's a very limited resources provided for evaluation. There's a real rush by many agencies to just get the messages out. Start the campaign, let's put on a show, let's do it, And they don't really plan it out very well, and that's why I think so many campaigns don't work very well. There was some really interesting meta-analytic research that Leslie Snyder and Mark Hamilton published a couple of years ago, where they evaluated the influence of health promotion campaigns. I think it was published in the Journal of Health Communication. You might check that out. And they showed that there was a very limited, very small effect, and there was also often quite negative effects from campaigns. And I think the reason for that is because they were not based on good data. There were not formative research being conducted. They were one-time, one-shot programs, and they weren't evaluated very well.
And Gary, here I have a question. Based on your own experience, when you conduct formative research, how do you make use of those theories? Do you use them as like a play in the background, or are you really, design your formative research revolving around some of the key theoretical variables?
Yeah, well, the theories basically help me identify what are the issues and questions and variables that I want to measure. For my example, I want to look at certain health beliefs, I want to look at values, I want to look at outcomes, I want to look at understanding or uncertainty. I may want to look at social support. Depending on the theory that I use, it identifies what are the criteria and variables that I want to measure.
But do you, for example, if now, one of the clients that you work with, okay, they have these issues and then they want to design some campaign,
do you just choose the theories that you feel proper, or you just feel like, oh, I'm going to test all of the theoretical variables that I'm familiar with? How do you?
Well, typically when I learn about a campaign, I'll try and think about what theoretical framework is going to give me the greatest understanding of why this is happening. Is it a fear issue? Is it a support issue? Is it a relational issue? Is it a media exposure issue? Is it a persuasion issue? And I'll try and pick the theories that will give me the most insight. And then based on those theories, I can think about what are the things I want to learn, and what are the things I'm going to measure to change. So in many ways, not only am I using the theory to guide what I'm doing, but I'm also evaluating the efficacy of the theory. But there's a broad range of theories. I may bring in tomorrow. I have a program I did for CDC not long ago where I went through a range of different behavior change theories that they could use, and you can get a feel for some of the theories that I think are most interesting. Many of them are probably familiar to you, but we can go quickly. You'll see some different theoretical frameworks. But for my own work, we all have our own patterns and predispositions. There's a couple theories that I use a lot. I use health belief a lot. I use stages of change a lot. I use diffusion of innovation. I use Weick's model of organizing. I use the relational competence model that I mentioned the other day in health outcomes. I use a number of different persuasion theories.
Because what we teach our students is that, okay, for the formative research, we do want them to have that theoretical bedrock, right, to support their design. But sometimes you can see that just based on our observations of student projects, that sometimes the way that they use the theory kind of sometimes can really limit the perspectives that they can really explore. So that's why I have these questions to you, that when you as a practitioner, when you use those theories, do you like doing mix and match, or you would just focus on one particular theory?
No, I usually use a combination of theories. I realize that no one theory is going to capture the complexity of the problem. So typically what I'll do is I'll use a variety of different theories that deal with different aspects of the issue. So it's not uncommon for me to have 4 or 5 different theoretical perspectives that are guiding an intervention and guiding the evaluation. Okay. Needs analysis. This is really kind of a summary. I think at the very beginning you need to try to figure out what are the issues, and what are the consumer needs, and what are the problems. I think this is, I typically get this information in a couple different ways. I do a review of the literature about the issue. I find out what the epidemiological data are about the problem. I'll look at previous research and surveys with similar audiences to find out what they know. I'll do interviews with experts who are working in this area, medical professionals, public health people, nurses, others who can tell me more about it. And then I'll look and I'll do interviews with people who are members of the community who serve that community as well, and find out what are the issues, what are the needs, what are the concerns. Audience analysis is basically, once you've identified who your target audiences are, you've got to get a better feel and understanding for who they are. And I usually use some kind of survey research, interviews, focus groups, and questionnaires. I personally like personal interviews, one-on-one. I learn the most from them. I worry a little bit about focus group, about groupthink kinds of issues where people influence one another. I worry about issues of literacy with questionnaires. So it's probably the most expensive of the 3 approaches, but I feel it's worth it. I also do a lot of observational research. I'm a real big believer in participant observation, of becoming a member of that community, or at least working with people who are members of that community. Sometimes I can't become a member because I'm so different from the community that I'm studying. So then I use cultural informants. So I think ethnography, typically in my work, I use survey research, I use ethnographic research, I use textual analysis, and I use experimental research. So I've got the full house there. I use all methods. I use both quantitative and qualitative approaches. I probably am more data-based than most interventionists are. It's probably because I'm more worried about doing something bad that'll hurt the population than others are, and I take more time. A lot of my intervention research programs are long-term, multi-year programs, and a lot of times agencies don't have that time. They have to respond very quickly, and it's one of the negotiations you need to do, and also is based on resources available. I would rather skimp on the sample size than on the data gathering. Sometimes, if I don't have the resources to do a full-blown representative sample, I will do a convenience sample where I feel that I'm getting a good representation. I'll try and build in some diversity. Sometimes I really invest in 2 or 3 cultural informants who really know what's going on, especially if I don't have a lot of time and a lot of money, rather than doing a full-scale survey, evaluation with a representative national survey, or representative survey of whatever the group is. Message testing. Typically I'll do both qualitative and quantitative message testing. Quantitative is basically, often it'll be done online, where we show people messages and we ask them to respond to them. And then the qualitative is that I do kind of a usability thing where I sit with people and have them look at mock campaign designs, where I get them to respond to what it makes them think about and how, what it suggests and what alternatives they would come. I find that the qualitative usability-based message testing often will tell me more, but the quantitative really will demonstrate the overall strength of the approach. And so I can use a combination. Feedback systems. Typically when I do health promotion programs, I'll build in mechanisms to provide audience feedback, like suggestions, reactions, questions. If it's an online system, there'll be like a button they can push to provide a comment. If it's a other form of media, I'll do follow-up interviews. I'll give people hotlines, telephone hotlines to call. I find that those feedback systems are not only really valuable for me in terms of learning what's working and what's not working, but it also provides opportunities to clarify and reinforce messages for audiences. So it's good both for evaluation, and it's also good for dissemination. I almost always will try and do baseline and trend outcome measures. The problem is that sometimes I'm called in after the fact as a consultant, as an evaluator, by agencies or companies to find out why their program, sometimes whether they don't even know whether it's working and why it is or why it's not. And then they bring me in after they've done it. And so it's very difficult to go back and do baseline measures. I have to go back and see whether there are some data points that already existed that I can hold on to, because I can't collect baseline data at that point. Or I can look for archival measures that existed, records, but then I try to track them over time. If I can't do that, if there's not good baseline data, the other alternative I do is I do control groups and comparison groups, where I try to find similar audiences that did not get the intervention, and then do some comparisons with them and track them over time. But if there's no comparison, either pre-post or across groups, it's very difficult for you to validate whether or not you've actually moved the needle and made a difference. And so that's where the experimental research comes in. It's always basically a field experimental designed to evaluate effectiveness. I also have learned the hard way that I need to do cost analysis. I need to figure out whether or not the expense of doing this type of intervention was worth the outcome, and whether there was maybe less expensive ways of doing things. Sometimes there may be one piece of the intervention that works best, and we can jettison other pieces that add to the expense. Typically, if I find out that there's a benefit in terms of reducing the cost of dealing with the problem, not just for helping the individual, but reducing the administrative cost, reducing the healthcare delivery cost, reducing any kind of penalties that might exist, that this becomes very good evidence for further investment in the work that I want to do. It also becomes rationale for institutionalization and sustaining whatever intervention. And without those data, you're not likely to get that type of commitment from sponsors. Best practices. I think this is my last slide. This is a summary. Build programs on fresh and revealing data. Don't depend on old data, old wisdom, colloquial wisdom, what you think will work, what people tell you is the most important thing. Use good data to guide what you're doing. Because more often than not, people are really not seeing things as clearly as they might. They're not really understanding the whole set of issues. Adapt to changing audience preferences, which means that you need to build emergent, changing, evolving intervention systems. Design strategic messages for specific audiences, and don't try to use a one-size-fits-all approach. Use multiple reinforcing messages and channels over time. Work closely with audience members. That's it. All right, so let me open it up for discussion. In terms of your work that you're doing, what kinds of ideas have you been thinking about in terms of needs and audience analysis and message design that might work for you? I'm hoping that I may have stimulated some of your thinking, or maybe you have some questions about how you might apply or utilize any of the ideas that we've talked about today. So I'm going to open it up for you.
I have a question.
Sure.
When you do, especially, we're in the message design phase a bit in our Women's Heart Health Project, and there are some things, like when you do your formative research on what the audience actually wants, or what they want it to look like, or what information they need, sometimes I find it hard for me to know whether it's just that one person or 10 people's opinion, or when to know when that's representative of the population, or when to, just people are so unpredictable. And so, I mean, it's built into CCA that we take it back to the advisory board and we go through several rounds of this, but just in terms of knowing what the audience wants, it's very hard to know if that person is speaking just out of like personal preference, or if that's something that is representative.
Yeah, there's a kind of a qualitative norm, data norm, that's based on saturation. So what you do is you kind of collect data and you see how many times you hear the same issues. And the idea is that you can cut off data collection when you stop hearing new ideas. It also suggests that when you stop hearing new ideas and you hear the same ones over time, that you can be pretty confident that this is what's going on. If you have an outlier who's just kind of blowing his or her horn, that sounds like what you're afraid of, you're not going to hear that theme over and over again. And I think you can throw it out if you've got enough. But it also suggests you need to have enough of a sample to achieve that saturation.
So this message, how was it designed? Or is it designed and taken back to the group, or is it coming out from the group discussion?
So it's come out from so we did interviews and advisory boards, and so each time the advisory board has we've consulted them about the information that we've heard, and then medical side is also producing some of the content based on what the women said that they wanted. So we will take that back to our focus groups and advisory board. And so it will go through that process, but, and maybe this isn't the best project. I just know, I mean, in terms of my question, but just, I don't know, it seems like, especially in a context where there are a lot of different cultures, different languages, it's hard to come to a, like, definitive, okay, this is what they want, or this is what the audience wants. So, but I think we're just at the beginning of this process, so once we go back and if we're hearing the same things still from our advisory board and focus groups, and
But isn't that the job of the advisory board to represent?
right, it is, and I guess that's my question is,
But I mean, why would you not ask them if that is a personal preference or if that is something that they believe or think is part of a community idea or perspective? Why not just ask them?
right, and we do. I just, as a like, if I sat on an advisory board, I think it would be hard for me to say between like, oh yeah, I think I'm representing everyone, but versus no, that's just my personal opinion. I think this represents.
No, but I think the saturation thing actually is
Yeah.
like the key issue, right? Because that will really give you some confidence about to what
Right.
extent that the data really speak for themselves. And
Right.
also the other thing that we usually do is that once you really have the idea about what are you going to do, you can always go back to your participants and then say, hey, is this really address your needs?
Right, and like I think that will come. We're just at the beginning, so we'll produce and then take it back several times. But I guess in a project that's not as CCA guided by that methodology, like as a health promoter or as someone designing a campaign. But I mean, what you said about saturation makes a lot of sense.
But I think regardless of whether it's CCA or not, I think that's the point Gary was making about the fact that we should be doing this, right? Involving the community, asking them, because our interpretation and what we hear might not exactly be reflective of what is resonating within the community, and I think that's regardless of whether CCA or not. And that's where most campaigns fail, right? It's like you come back, you have your group, and then you design, and then voila, it's magnified. But then the group that you got the information from looks at it and goes, "Who are you talking about? And is that really me? Is that supposed to be me?" But I think that's an underlining strategy. It should be an underlining strategy, I think, regardless of what theory or approach you take. Is that if you don't do that, then the chances are that it's not going to resonate with the community.
How are you collecting the data? Are you doing interviews with individuals?
Interviews, and then we have an advisory board that we've met with, and then we'll take it to focus groups and then back to the advisory board.
How many interviews?
Almost 20, 15 to 20.
Then how big is the advisory group?
Total is about 10 to 12, but it's been different combinations of people each time.
And who are the advisory board members?
They're women there are 50 women in our intervention group, but it's a randomized group. So they were randomized into the advisory board, focus group, or interview. So there are women that will ultimately also participate in the intervention, but I have just been randomized and assigned to our advisory board.
I think I would have probably used a more selective strategy to put people on the advisory board. Like, people who have lots of experience, people who are angry. I like angry people,
Right.
but if you're angry about the issue,
Well, I think one of the thoughts we had is that a lot of the women who are ultimately the most marginalized are the ones that aren't brought to the table to talk about this topic. So by picking them, our hope was that this randomization would allow women of different languages that aren't generally the ones that would step forward and say, like, I want to talk about this, but that may need access to.
Which I guess also raises the question of, if you're randomly placed in an advisory group, you might not necessarily be comfortable to, one, play the role of an advisor, or B, feel like you could represent the community, right?
Well-
So it's sort of a hit or miss kind of a chance that the person is going to be vocal and be opinionated and be able to say this is what our community stands for, or this is what we think is right for us. So
Well, they
it's
were
sort
told
of
at
a-
recruitment, like if you agree to this, you'd be randomized into the advisory board. So at that point, they could have said, I don't want to participate or don't want to be in the advisory board. But I mean, that point is valid too. But at the same time, if you're only choosing people who think that they're fit for an advisory board, you're going to hear the same voices all the time, right? The women who are more.
But I think but in terms of the people, once they have been selected, randomized in the 50 women, you could have asked who would want to be in the advisory group,
We
as
did.
opposed to assigning them or randomizing them into that group.
Well,
'Cause-
I asked my interviewees too if they wanted to participate as well in the advisory board, but it was a randomized control trial, so it, to some extent had to be randomized, so that's
They're
just
working
how
with the university hospital, so there's
Yeah.
sometimes there's logistical
Right, right,
limitations.
right,
I'd like to step back, and look at your project a little bit, if you don't mind.
sure.
What do you want to happen? What is a goal you want to achieve?
Well, there are several. One goal for us is that we want to see the relationship between this social scientific approach to intervention and link it with this biometric data. So to see if this planning of an intervention of what the women actually want will in fact improve or not their actual cholesterol levels, their blood pressure, their also their knowledge levels of what symptoms of heart attacks are, with the ultimate goal that will lower the rate of cardiac deaths in Singapore, which is the #1 cause of death for women here. And then on another level, our hope is that this intervention may be able to be applied to more nation-based national intervention. So I guess there are several goals. And then on the other side, the hospital's goal is to see if there's a relationship between these women seeing women cardiologists, if that's going to help as well improve those
Are there
biometric
specific
indicators.
things that you want the women to do?
Yeah, well, so through the intervention that they've said they want more information about diet, exercise, and stress management. So we aren't technically measuring if they're doing those things, but whether they know about them, what their attitude towards them are, if that is in fact translating to lower levels of those risk factors. Does that answer your question?
Uh-huh.
Okay, sorry.
I mean, I was thinking about the things I was saying before, that, in planning, you want to kind of know what you want to accomplish.
Mm-hmm.
You want to figure out who your audience is. You want to figure out whether they can do those things or not.
Right.
It's kind of like, trying to apply that template to what you're doing to see if, maybe it was some way to kind of refine what you're doing.
Mm-hmm.
And then what kind of interventions are you expecting to?
Well, they've identified that they would like once a month for interventions in which a nutritionist, a nutritionist, an OT, and a PT, and a cardiologist speak to them on topics that they've identified, and then allow for question and answer with them. So it'll be starting in March.
It's like a
April,
health
May, June.
education intervention.
Mm-hmm. Mm-hmm. Yeah.
There's probably a lot of unknown, addressing the unknowns in. I mean, you go to the clinic, right? They say the information is on the pamphlet.
Right.
It goes back to the point of, is it accessible? Do you understand it? It is something, as opposed to say, here, A, B, and C, you do, right?
Right.
And to say,
So I think a lot of it will maybe depend on how well the clinicians do in communicating that information.
Yeah, and hopefully, one of the big things they said was that they want that time for question and answer and to talk with the other women that are there about different topics or questions or things that they don't either don't think about an appointment or don't feel like they can ask openly or.
So it sounds like maybe there might be a kind of a group support dimension or another intervention. I have a feeling that that might be really nice intervention too.
Yeah.
What about, any kind of like a mechanism for disseminating information beyond the presentations? The thing I worry about the presentations is that you can't control for how easily they'll be understood or how well retained
Right.
the information is.
We're also designing a interactive, that they can, kind of like a brochure that corresponds with each session that each allied healthcare professional is delivering. So it'll be things that they can do goal setting and take notes or whatever and take home with them. So that's also something that they identified as something that they wanted, something informational that they can take home that will correspond with the sessions that the clinicians were doing.
I wonder if there may be a way of videotaping the presentations and making them available
Yeah,
so they can
that's
review them over time. Or maybe do some kind of written summaries
great. Yeah.
or discussion groups. Especially because if they don't understand, there might be some good opportunity for unpacking. Plus, it's kind of hit or miss whether or not the clinicians will actually bring up specific concerns and issues that the women have. And if they have an opportunity to push that.
Yeah, so I did a summary of the data we collected and gave that to the clinicians. So they should be designing their content based on the concerns that the women have voiced in our advisory boards and interviews. So hopefully they'll address some of those or field them and question the answer.
What about feedback mechanisms? We were just talking about that. Do you have any feedback mechanisms built in?
To the intervention design? No, but that's a great idea.
So that's the thing about that. What kind of feedback mechanisms could there be? Let's say if people don't understand and they're confused, what can they do to kind of get more information? Could you give them maybe a phone number to call?
Sure.
But then you'd have to pay for somebody to answer the phone.
I have a feeling it would probably be mine.
And you'd have to be knowledgeable enough to answer their questions.
Yeah.
So if they called you up and asked about a mitral valve, procedure, you'd be able to give them good information.
Yeah.
Or know who to refer to.
No, yeah.
So what is the key message of the intervention? There's different platforms and channels and ways of addressing your concerns, but what is the message that ties all of that?
I guess it would be, so all of these women already have had issues with their heart, so it's about maintenance and things that they can do to maintain heart health once they've already had issues. So exercises that they can do, even most of these women are 50 to 80, so exercises that they feel like they can do, and eating, not having to cut out some things. They're saying, I don't want to cut out, but I'll cut down. So feasible eating things that they can do, and then how to be happy and manage your stress. And so I guess the key theme is maintenance after.
Sounds like successful survivorship.
Yes, exactly. Like that.
There's a really nice literature about survivorship. There's actually a journal of survivorship that came out a couple years ago. I'm on their editorial board. There's a lot of good things that you might look at.
Journal of Survivorship?
I think it's Journal of Cancer Survivorship, but I think it might be pretty applicable to a wide range of diseases.
Yeah, great.
It sounds like there might be a lot of psychosocial issues involved in their successful survivorship. I mean, there's some physical things with the exercise, but there may be some dealing with fear of reoccurrence of heart disease, dealing with the side effects of treatment. A lot of times they're taking medication and they make them feel dopey.
It's probably why they want those sessions or want to ask when you have a question and answer session in terms of.
Sometimes the medications have like really creepy effects like on digestion and sleep and pain, suffering, nausea. So, that kind of gets back to what we talked about yesterday about palliative care, the ways of trying to make sure that people are more comfortable. But there's also both kind of a physical and a psychological dimension to that. We're talking a lot about the physical, but I think there's maybe a psychological part of like providing social support, encouragement, boosting people's self-image. There's always, a lot of times people who have serious health problems start feeling like a victim. They feel bad about themselves. They feel like they're not worthy anymore. They're not good people. They're not whole. They're not valuable. They're not action folks, leaders, That's why I think a lot of times people who've been through serious health problems like to become helpers to others, advocates, because it kind of gives them a role of importance and credibility and relevance that they don't feel like they have anymore. Like a lot of folks who go through serious heart disease give up their regular jobs, so they don't have that identity anymore. Somebody else picks up some of their responsibilities of maintaining the home or taking care of children or doing other, so they can lose that role. So they're trying to figure out who they are and why they are there and what do they have to contribute. That's why I like the idea about the support groups. I think that'll be better at achieving those psychosocial.
We did ask them if it would, what they thought about, because they wanted to do small group things in the intervention, and we said, well, would it be helpful for us to encourage swapping numbers or meeting together outside of the intervention? And they said that they probably wouldn't do that, but that they would meet together at these interventions. So maybe that will spur on.
I wonder if you could do kind of like an online support group.
Well, most of them don't have access, or they may have access, but they don't use the internet.
How about mobile?
Some of them do, but I would have to see. Some of them do. A lot of times you have to go through their son or daughter to get to them, usually on the phone.
I would also think that, right? I mean, even if you ask us, and you say, oh, we're going to start a social, group, and then would you, meet with them and give them numbers? Most of us are going to say no, anyway, right? It's a matter of trust and getting to know people, and so maybe that's something that you achieve or will come. But I would imagine for most of us, even I can imagine just saying, yeah, sure, give it out, and I'll just meet with random people. To me, at this point, right? They're all random. We don't know who what, so it could just be that.
Or maybe
it's a matter of creating a space to build that.
Maybe at the beginning you can have more structured social support groups, because based on a similar study we did before, in general, women at that age, in that age group in Singapore, they are busy because they have to take care of their spouse, but also their grandchildren.
Right.
So maybe that's I don't know, maybe you can explore more about whether, time management is one of the major reasons that, they couldn't find more time to, meet with, other women, mainly not because they don't want to, but maybe because they have other, commitments to do.
Yeah, that's exactly what they said.
So
just that they didn't have, they don't think
But
they
if
would.
you're bringing them in for the intervention already, they're coming in for those talks.
Yeah, it's hard to get them. That's a challenge in and of itself to get them in, and a lot of them aren't very mobile because they're either wheelchair bound or depend on their son or daughter to bring them in. They're very old, and so.
And I think heart health is racialized as well for women, because the literature seems to suggest that there are racial lines for why cardiac arrest might happen, and the thing is that Indians are at the highest risk, but they survive it. The problem with the Malay community is that they don't get access, or they have limited access because of socioeconomic reasons and so on. So by the time they actually survive. They are the least likely to survive the cardiac arrest. And so maybe exploring this from a racialized perspective, I think might be useful.
Maybe you could break it into different groups based on racial.
They will be broken up by language.
Which
So
also in Singapore, I guess it divides you.
Mhm.
I'm not sure if maybe
Just a more different way of saying racial. Really, I mean, I'm not going to speak Chinese tomorrow. I'm likely going to be in this group, but hey, it's not racial, you know, this kind of language. But I'm saying Singapore because we don't talk about the racial aspects of racial differentiation, but language. If you talk about religion or if you talk about food, it's going to separate that out anyway.
which also might be interesting because they might prefer support networks that might be of their own religious background, in particular language, especially for women in that category or that age. Because I find it a struggle to, when I conduct, like when we do health interviews with that age group, there's always a barrier, despite me being a Singaporean and being able to speak some level of Mandarin, it's still a barrier. Because at the end of the day, it's very hard to get the information you require that a Mandarin speaking individual might be able to do, or somebody that might be. Yeah.
Yeah.
So what are the languages that these women are speaking? Mandarin?
The main three are, it's mainly Mandarin and English, but we also have Hokkien, Cantonese, Tamil, Punjabi, Teochew,
Malay.
and Malay.
Dialects.
So
It's not so much for the generation that might be below 50. It is the 50 to 80 that still has those, that the language barriers are still quite.
But most of them might not even be speaking English.
I'd say more than half don't speak English.
And of the presentations by the providers, which language are they going to be using?
There will be a set, so all of the Mandarin-speaking patients will be together, and then the English-speaking patients will be together, and then we'll have a separate Malay group, and then for the dialects, we'll have translators with them with whichever is, so like Teochew, Hokkien will be with the Mandarin group, and we only have one Punjabi, one Mandarin, so we may, depending on where that.
But the clinicians themselves, the ones that are delivering, do they speak those different languages? Oh, good.
Yep. For Mandarin, Malay, and English.
And the dialects?
The dialects will just be translated.
Oh, translated.
Yeah. Just because they're only like pockets of a few, one
So
or
for
two.
those who speak dialects, do they also speak Mandarin? Or is it only dialects?
Some, I know there are, I'd say between 5 and 10 that are only dialect.
Are they from the like much older age group, so not 50 but 70?
I'd say like 65 to 80.
Do you have any baseline data on, so what are baseline data points?
There are two, well, we do all of their like cholesterol levels, their waist measurement, their body fat. We do a body fat analyzer, height and weight, and then 2 surveys. So one is a women's heart health specific survey that we developed here, and one is from the clinical side, and it is, I can't remember it's called like SF356 or something, but it does, there's some questions about depression, about how well they feel now based on a year ago. So they're, I guess like, it's not we did have the Duke Depression Scale, but that's not it anymore. It's kind of like a lifestyle assessment scale about how they feel about their health and what they're able to do and not able to do.
So it's almost like a wellness.
Yeah.